Hi, I'm Dr. Matt Goebel. I'm a resident at Baystate Medical Center, and I'm going to be talking to you today about NSTEMIs that need the Cath lab now. Now, you might be thinking to yourself, what do you mean NSTEMIs that need the Cath lab? STEMIs go to the Cath lab, NSTEMIs don't. Well, that's because we've created this false dichotomy between STEMIs and NSTEMIs, Cath or no Cath. And part of that is what we're calling what. So for the purposes of this presentation, I'm talking about a STEMI as something that very strictly meets the millimeter criteria, of which there are several different published versions that have varying degrees of sensitivity and specificity, versus an NSTEMI, which is one that just doesn't meet those criteria. Whereas both of these will have a rise and fall in troponin, as is the universal definition of MI. But then comparing that against, was there an occlusion or was there not an occlusion? Now, typically, we think STEMI, occlusion, that's your type 1 MI. And NSTEMI, no occlusion, that could be like a type 2 MI. But there are other kinds of EKG patterns that indicate an occlusion but don't meet the strict millimeter cutoffs of being a STEMI. But that patient would still benefit from going to the Cath lab and receiving reperfusion. So today I'm going to talk to you about 5 EKG patterns that are like this. They don't meet that ST elevation millimeter criteria, but these are patients that have an occlusion and would benefit from going to the Cath lab. So they are isolated posterior MI, high lateral MI, De Winter's T-waves, left bundle plus a STEMI, and hyperacute T-waves. So the first pattern I'm going to talk about is an isolated posterior MI. These represent 3 to 11% of MIs, and they're often under-recognized. That's exhibited by the fact that these, on average, have a door-to-balloon time of 29 hours. So there's often a delay in recognition. Now, comparing, the main feature of a posterior MI is lots of ST depression across the precordium. Another condition that we think of that has a lot of ST depression across the precordium is left main insufficiency, what some people call left main occlusion. So you'll see, comparing those two, a posterior MI has maximal ST depression in V2 through V4, whereas left main has maximal depression in V5, V6. In a posterior MI, you're also going to see tall R waves forming, or what some people would call an early precordial R wave transition. As you can see on the left main EKG, the QRS is predominantly negative, is completely negative in V1 and is mostly positive in V6, and that transition occurs usually somewhere around V3, V4. Whereas in the posterior MI, that transition from mostly negative to mostly positive occurs much earlier at like V2. This is because Q waves forming from the posterior wall show up as R waves when we're looking from the front. One thing that we always think about with posterior infarcts are posterior EKG leads. So the way that you do that is by moving V4, 5, and 6 around to the back. They're going to be in the same horizontal plane as 4, 5, and 6. You're just going to follow them around, and you're essentially doing posterior axillary 7, mid-scapular 8, and paraspinal 9. Now, posterior leads are a bit of a double-edged sword. The first issue is, what do we use as our criterion cutoff? So if we use 0.5 millimeters, it's 94% sensitive and 100% specific. If we use 1 millimeter, then it's just 49% sensitive. So we're only looking for a half millimeter or less than one small box, half a small box, to identify MI, posterior MI, using posterior leads. That can be kind of hard to see. And to make things even less fair, 22 to 39% of posterior infarcts do not have any ST depression in the anterior leads in V1 through V3. So there's another trick we can do. But first, I want to ask you, is this the Mona Lisa? Just really quick, your gut reaction. Probably yes. But actually, no. Our eyes are trained to recognize things when they're in a certain way, and changing the orientation can vary that dramatically. So when we look at an EKG, we need to be prepared to do it in a way that is going to optimize our interpretation. So what we can do is take the EKG and flip it over and hold it up to the light to look at it basically upside down as though we're looking through the back. And when we do that, the ST depression is viewed at ST elevation, and it can jump out to us much more readily. So that's another trick for helping your mind see the ST segment changes. So the next pattern I'm going to talk about is high lateral MI. The most important thing about high lateral MI is the reciprocal changes. Now, reciprocal changes are the relationship between 2-3 AVF and any other lead. When we have depression there, we look for elevation elsewhere, and when we have elevation there, we look for depression elsewhere. Now, with the high lateral MI, the most important part of this relationship is between 1 and AVL. So in these infarcts, we will see very minimal ST segment changes in 1 and AVL because the angle of the ST elevation is perpendicular to those leads, so you don't see much ST segment change. So the tip off here is seeing ST depression. So when we see ST depression in 2-3 and AVF, we should be looking immediately to 1 and AVL to see if there are any signs of ST segment elevation or T-wave changes. Now your bonus tip is, well, what about a subtle inferior MI? So if we think that we're seeing inferior ST elevation but we aren't sure, we can confirm our suspicion by looking in 1 and AVL. And if there is any depression up there or new T-wave inversion, and we think that we see depression in 2-3 and AVF, then we can be sure that this is an infarct and should go to the Cath lab. So the next pattern I'll talk about is the De Winter's T-waves. De Winter's T-waves represent about 2% of LAD occlusions. Now, classically, they have been described as you see the pattern and it stays that way until the artery gets opened. They classically don't have any dynamic or evolving changes, but as we'll see in a second, that's not always the case. Anyway, to recognize them, we're looking for a large hyperacute T-wave as well as some ST depression. So here is a De Winter's patient. This patient, however, later went on to develop ST elevation in a very traditional, sort of obvious looking anterior MI, but this isn't always the case. There are also case reports floating around out there of patients that have gone the other way. They've gone from ST depression back to the De Winter pattern. So we have to be looking for changes, even though they may not be there, because classically the De Winter pattern is present until the artery is opened. So our next pattern is going to be STEMI with a left bundle branch block. Now, left bundle branch blocks are supposed to have some ST segment elevation. When the QRS is mostly down, there is ST elevation. When the QRS is up, then there's ST depression. This is called appropriate discordance and is a normal expected finding for left bundle branch blocks. Now, what we need to be concerned about is when we see changes that go the same direction as the QRS complex. So if the QRS is mostly down and there's ST depression, or if the QRS is mostly up and there's ST elevation, then we should be concerned. That's part of the Scarbosa criteria that we all know and love. The last part of the Scarbosa is this ST elevation greater than 5 millimeters, which traditionally has not performed very well. So there is a new modified version of the Scarbosa criteria developed by Steve Smith at Hennepin County, where rather than using an absolute millimeter cutoff, they use a proportional cutoff of 30% of the depth of the QRS. So if the ST elevation or ST depression is greater than 1/3 of the size of the QRS complex, then that is excessively discordant. This was found to be both highly sensitive and specific, and perform much better than the traditional Scarbosa cutoff of 5 millimeters. So the last pattern that I'm going to talk about is hyperacute T-waves. Now, hyperacute T waves are just really big T waves, but you may be thinking to yourself, I thought that meant hyperkalemia, and how do I tell the difference? Well, there are several features that differentiate the two. Hyperkalemic T waves are symmetric. If you draw a line down the middle, it looks the same on both sides, whereas hyperacute T waves are asymmetric. Additionally, there's this whole idea of concave up, convex down, concave down. People describe them different ways, but if you are suspecting that the patient has hyperkalemia, it must have a concave up or smiley face morphology. If you are thinking hyperkalemia, but it looks the other way and is a frowny face, hyperkalemia is not allowed to have frowny face T waves. Hyperacute T waves from an infarct could be smiley face, but frowny face is nearly always bad. So don't mix those up and don't fool yourself by always finding smiley face reassuring. So in summary, we talked about 5 different EKG patterns that do not meet strict ST elevation criteria, but do indicate an acute occlusion causing an infarct, and the patient would benefit from going to the cath lab. They were isolated posterior MI, high lateral MI, De Winter's T waves, left bundle branch block plus a STEMI, and hyperacute T waves. So in summary, if you see ST depression in the precordium with tall R waves, think posterior MI. If you're thinking posterior MI, flip the EKG over and look at it through the light so the ST segment changes may jump out to you more, and consider doing posterior leads, because even a large fraction of posterior infarcts may not have ST segment depression when done from the normal anterior placement. But if you do posterior leads, you may see those subtle changes. If you see inferior ST segment depression, look to 1 and AVL. And if we see ST depression with big T waves, think De Winter's, and that's an MI which may or may not have dynamic changes. Left bundle branch block plus ST elevation greater than 30% of the QRS is the new Steve Smith validated modification to scarbosa, which is indicative of MI. And asymmetric plus a frowny face T wave should be concerning for MI.